Hello, my name is Dr. Dewan S. Raja. Today I will discuss about Staphylococcal Scalded Skin Syndrome. Staphylococcal Scalded Skin Syndrome, SSSS, also known as Ritter disease, particularly in newborn, is a serious skin infection caused by exotoxin-producing strains of Staphylococcus aureus. Caused by Staphylococcus aureus that produces exfoliative toxins. This toxin target desmoglein, a protein that helps whole skin cell, particularly the epidermal cell, together, leading to epidermal detachment. Most common in infants and young children under 5 years. Can also occur in immunocompromised adults, though it is rarer. Okay, this is the image taken from Google Image Dermatology Med Bullet 2. Newborn with features of Staphylococcal Scalded Skin Syndrome. The epithelium is coming out, there is exfoliation. It involves almost entire part of the body. It can involve face, the abdomen, the genitalia, the lower limb, upper limb may be involved. And it may happen within the first week of birth. Pathophysiology: toxin enters the bloodstream and spreads systematically. They act on the skin, particularly at the stratum granulosum, causing separation of the superficial epidermis, results in widespread blistering and skin peeling that resemble a scald or burn. Superficial wound cultures are sterile. Okay, so the toxin is in the blood. There is no bacteria on the superficial wound is found in Staphylococcal Scalded Skin Syndrome. Clinical feature: fever, irritability, tender erythematous skin, usually starts around the mouth and spreads. Flaccid bulla, fluid-filled blisters, positive Nikolsky sign, skin slough off with gentle pressure, desquamation, peeling of large sheets of skin. Differential diagnosis: toxic epidermal necrolysis, bullous impetigo localized version, Kawasaki disease, Stevens-Johnson syndrome. Okay, so this is a differential diagnosis. Bullous impetigo, the local lesion, will found particularly on the mouth. The lesion will get the bacteria. Okay, and toxic epidermal necrolysis may involve the mucosa and is a total thickness epidermal loss. The Kawasaki disease will get the rash, as well as we have coronary artery dilatation. Stevens-Johnson syndrome, okay, that, and both of them may be associated with that of drug exposure. Will get the, again, epithelial separation as well as mucous membrane involvement. Okay. Diagnosis mainly clinical, culture from nasopharynx, conjunctiva, blood, blisters are usually sterile. Skin biopsy rarely needed, shows intraepidermal cleavage at granular layer. Treatment: hospitalization is usually required, especially in children. Intravenous antibiotic like nepenicillin, oxacillin, or vancomycin for MRSA coverage. Supportive care: fluid and electrolyte management, pain control, wound care. Prognosis: good in culture with prompt treatment. Mortality is low in children but higher in adults with underlying condition like immunocompromised condition. And we have some MCQs on Staphylococcal Scalded Skin Syndrome. Let's start to solve them. A 2-week-old infant presents with fever, irritability, and large areas of skin peeling. Nikolsky sign positive, gram-positive coccus is isolated from the nasopharynx. Which of the following best explain the mechanism of the skin findings? Direct bacterial invasion of the dermis, immune complex deposition in the dermis, production of exfoliative exotoxin targeting desmoglein 1, D. Hypersensitivity reaction to bacterial antigen, E. Superantigen mediated cytokine release. Answer should be C. Production of an exfoliative exotoxin targeting desmoglein 1. This is the answer. Okay, this is the mechanism of the Staphylococcal Scalded skin syndrome. Production of exfoliative exotoxin targeting desmoglein 1. Question number 2. Which of the following layer of the epidermis is most directly affected in Staphylococcal Scalded skin syndrome? Stratum basal, stratum spinosum, stratum granulosum, stratum lucidum, stratum corneum. This is mostly this, stratum granulosum. Okay, C is the answer. Question number 3. A 3-year-old child with recent Staphylococcal aureus infection presents with generalized erythema and skin sloughing. Which of the following feature best differentiate Staphylococcal Scalded skin syndrome from toxic epidermal necrolysis? Presence of fever, positive Nikolsky sign, involvement of mucous membrane, history of recent infection, skin blistering. Okay. Best differentiate Staphylococcal Scalded skin syndrome from toxic epidermal necrolysis, involvement of mucous membrane. Usually in Staphylococcal Scalded skin syndrome, no involvement of the mucous membrane. But in toxic epidermal necrolysis, this will be a full thickness epidermal loss, plus we have involvement of the mucous membrane. That's all about the Staphylococcal Scalded skin syndrome. Okay. So if you have any question, please feel free to ask me. Please share the information with your friends. Please support my channel. Please subscribe me. Have a nice, wonderful and blessed day. Bye now.